Tushar sir, can we start now?
Yes, I think we are on time. We should start. Are all the panelists who are attending ready?
Yes, yes. I'm ready to share.
Good.
Totally share.
Okay. And Dr. Gopinath team, just check with Dr. Gopinath. If he will join later on, it's fine. We can start on time.
Okay, sir. Good evening, everyone. My name is Sapna Nevar, and I will be your host for tonight's scientific session. On behalf of International Association for Integrated Oncology, IAIO, I would like to extend a very warm welcome to all our esteemed faculties and delegates from across the country joining us today for the webinar Expert Insights Hemato-Oncology. Today, we delve into the evolving treatment landscape of CML and the critical role of patient blood management. It is my honor to introduce our program director, Dr. Tushar Pandey. Dr. Tushar Pandey is a leading clinical hematologist, hemato-oncologist, and BMT specialist based in Haldwani, Uttarakhand, serving as director and head of the Raghav Institute of Hematology. Now we invite our esteemed faculties, Dr. Satrupa Mahapatra, hemato-oncologist, Dr. Jay Juvikar, clinical hematologist and hemato-oncologist, Dr. Gopinathan M, hemato-oncologist and bone marrow transplant, Dr. Shilpa Gupta, hemato-oncologist and cellular therapy specialist, Dr. Saksham Singh, medical oncologist. Now, to lead our first session, we welcome our program director, Dr. Tushar Pandey. He will be presenting on the treatment landscape in the management of CML. Sir, the floor is yours.
Sir, we are unable to hear your voice. Actually, it is.
Yes, sir.
Am I audible?
Yes, sir.
Yes, can share my screen once. Okay. So, okay, is my screen also visible?
No, sir, it's come. Yes, sir.
It's visible?
Yes, sir.
Okay. Right. So I welcome everybody and thank you for sparing your time for this great academic session orchestrated very nicely by team IAIO. So CML remains a it has a very special space in the hearts of all hematologists. While because there was one time where CML was treated as a strong leukemia, a very strong dreaded blood cancer. But with the advent of tyrosine kinase inhibitors, the treatment landscape for CML has changed. Now, in our OPDs, we are very comfortable and we comfort the patient that it is CML. Don't worry, it is a disease that you can live with all the joys and happiness of life, just with a single pill of medicine. So, the topic is treatment landscape in CML. We will be dealing with the basic definitions, the basic management landscape, how to approach a case of CML, and what is going on in daily practice. Before which we will also see important studies which led to the use of various drugs that we use in CML. So from precision therapy to treatment-free remission and beyond. So the outcomes of CML have changed immensely with the advent of TKIs, where the global incidence is very variable for CML around 1 to 1.5 per 1 lakh population annually. The impact of targeted therapies has been so strong that a 5-year survival of more than 85% is achieved for all the patients of CML on TKIs, be it imatinib, be it any other tyrosine kinase inhibitor. So in this era of TKIs, we have more than 85% 5-year survival, and early detection, better management of CML with the TKIs has led to improved outcomes and a patient-centered care. So before moving ahead, we all know that when it comes to CML, the common presentations are fatigability, pain abdomen, splenomegaly, and weight loss. While as per the data, fatigue has been observed in 85.3% of the patients. Pain abdomen was reported by 83.3%, while splenomegaly, which we see very commonly, is around detected in 80% of the patients, while weight loss is also a common symptom. So before moving ahead, let's delve into the history a bit. So it was in the 1950s that Dr. Novell and Dr. Hungerford, they discovered the Philadelphia chromosome, which was the first consistent chromosomal anomaly in any cancer. Followed by which around after 20 years in 1970s, Dr. Janet Rowley, she discovered that translocation 922 is the translocation that forms the Philadelphia chromosome. While in 1980s, Nora Hesterkamp cloned BCR, and this gentleman here, Dr. Owen White, he identified ABL1 as a key player in CML. And we all know this famous picture when in the late 90s, Dr. Brian Ducker and Nicholas Leiden, they developed the wonder drug, imatinib, that changed the treatment landscape for CML and so on. After which various studies have done and numerous players have come into the play. Now, what is CML? What is basically happening here? So there is a translocation between chromosome 9 and 22, which leads to formation of a derivative chromosome 22, which we also call it, there's the Philadelphia chromosome. This CML is rare and accounts for around 50% of the leukemias, and it's slow growing and is a higher survival after the advent of new treatment. So when we do a workup, we come with the various treatment modalities. So the typical findings on the morphology in the smear is around we have a leukocytosis with left shift and basophilia. And this has the bone marrow aspirate, which shows granulocytic hyperplasia, some reduced erythropoiesis relatively, and other features like pseudogorgia cells and dwarf megakaryocytes. Then coming to the genetic part, which helps in the diagnosis, the classically used form was karyotyping, in which we used to get the 922 translocation. And this is the chromosome 22, the derivative 22, the Philadelphia chromosome that we find. Along with that, FISH is also used, which is very helpful in finding cryptic mutations, which we do not get in our routine PCRs at times. And the most used modality to confirm to a CML is the RT-PCR. So talking about RT-PCR, we should also know the breakpoints that are present in the BCR gene. So we have three breakpoints. The most common one, the major one, the P210, is seen in around 95% of the CML patients. The other one, the minor transcript, is the P190, which we see in the acute lymphoblastic leukemias that are Philadelphia positive, and is also seen in ALLs with monocytosis. The third form is the rarest and is the microform, that is the P230. It is seen with CML with prominent granulocytic maturation and in chronic neutrophilic leukemias as well. So clinical relevance of these transcripts is very important. That number one, that they do help in the diagnosis. They also help in the treatment monitoring. While it is the P210 in which the IS scale is developed and we can quantify it and monitor the treatment outcome. While for others, we may have to go for a qualitative analysis. The therapy response, yes, most patients respond well to TKIs, and we are able to get that through these transcripts only. Now, just a basic update to CML. We all know now that it is just a chronic phase and a blast phase. Previously, we used to have a chronic phase, an accelerated phase, and a blast phase. Now, as per the latest updates, it is just a chronic phase and a blast phase. And the entities that used to come under accelerated phase are now just termed chronic phase with the high risk features. So staging is important, and this ambiguity was removed basically because it was very difficult to start which kind of treatment for people with accelerated phase. So what they have done in the guidelines is divided into two, only chronic phase and a blast phase. While for the blast phase, we use the treatment that we have. In the accelerated phase, if the number of blasts are lymphoid blasts, although it's not in the guidelines, if the blasts are lymphoid, even with a low percentage, you can start treatment for the blast phase. While for the myeloid, the still cutoff of 20% still lies there to qualify it as blast phase. Now, the other important thing that we should all know when it comes to CML is the risk stratification and the scoring that we do for that. So the first scoring that came in 1984, which is the pre-TKI area, was the so-called scoring, which included parameters like age, spleen size, platelet count, and peripheral blast count, and had three risk stratifications like low risk, intermediate, and high risk. It was useful, but in the modern TKI area, it is less accurate. After it in 1998, the Hasford system came. Now, this was developed in the time when interferon was rapidly used. So it's like a refined so-called score, but better than in, but it is very less used now because the parameters, if you can see, are age, spleen, platelet, blast, eosinophils, basophils, and it's very difficult to keep the track of all of them. So in 2011, the UTOS or the European Treatment and Outcome Study scoring developed, which was very simple, and just two parameters were there, the basophil percentage and the spleen size. Now, this was in the early TKI area, and this was more based on the cytogenetic response that was evaluated at that time, and it predicted the treatment response with TKIs. So, although very useful, but then the shift changed to a more of a PCR-based model, and a long-term survival became a more important part of the therapy when all the therapies produced very good results. So the ELTS score was developed in 2016, which is the UTOS long-term survival score. It was designed for the modern TKI therapy that we use and had four parameters only: age, spleen size, platelet count, and peripheral blast count, dividing to low, intermediate, and high-risk categories. And it is the best tool now for long-term prognosis when we treat the CML patients with TKIs. So this is the quick comparison again. And so ELTS is best for survival prediction, while UTOS is useful for response prediction. Now, treatment approach in CML. Just before moving ahead, we should know the four broad points. One is which agent should be used as the first line therapy. Should it be imatinib? Should it be dasatinib? Should it be Nilo? Should it be Bosu? Or now should it be ponatinib? It's important to know various factors before we comment on these things. Then response monitoring, when to do response, how to do response. These are important things when we start the treatment. Optimizing the treatment so that there is tolerability, because many a times we know as when we start patients on TKIs, there is a high discontinuation rate if there is a toxicity in the initial part of the starting of the treatment. Now, advanced refractory CML, we should consider TKI switch whenever we have certain resistant mutations like T315I, etc. And it's important to know these things because like these patients are good candidates for transplant as well. So start selecting the TKI in CML. We should do in this systematic manner. The most important thing is assess the patient. What kind of a patient are you dealing with? What are the disease factors? What is the phase? Is it the chronic phase? Is it the blast phase? What is the risk stratification? It's a low, intermediate, high risk. What are the genetic factors? Are there some baseline mutations? Now, this is a very difficult area because not in every centers will you be able to do a baseline NGS or a mutation analysis besides the BCR-ABL1. So if we are endowed, patient is not having issues, I think doing a baseline mutation is very helpful. But that is not applicable on a practical aspect everywhere in India. Now, the patient factors, like what is the fitness, what is the ECOG score, what are the comorbidities, and how is the organ function of the patient. The treatment considerations, what are the drug interactions, what are the other drugs going on? Is the rifampicin patient already on anti-tubercular therapy, enzyme inducers, enzyme inhibitors? What are going on besides the routine treatment? Then the patient preferences as well. Now, there are various guidelines. We see patients. Now, at the end of the day, my first question to the patient is, what do you want? At times, we forget that it is the patient who who will be taking the treatment. And we try to put what we want on the patient. Now the time has come, we have a patient-centric approach, and we ask the patient, what does the patient want? And then they determine the treatment goals and also plan for a good quality of life. The second one is to define the treatment goal. As I have said, we have to achieve deep response, maintain a long-term control, and enable a treatment-free remission. Now, TFR or treatment-free remission needs discussion. We'll be discussing it later on. And not everyone is a candidate of TFR. We'll get to know it later ahead. Now, choose the most appropriate TKI that we have already said as per the various these factors, comorbidity, what the patient wants, and other long-term considerations. Fourth point is we have to regularly monitor, assess response, the key milestones, manage the adverse events, adjust therapy when needed, aim for a deep and durable response and a better survival. Now, coming to the various therapies available, we know that various frontline therapies available for CML CPR front are imatinib, dasatinib, nilotinib, and bosutinib, which can be used in frontline. Now, coming to the landscape, we have already discussed the late 1990s, imatinib was approved, then followed by dasatinib around 2007, then the NSTIP trial for nilotinib, which led to approval around 2010, then other players like bosutinib and ponatinib, and recently asciminib also approved in 2021. So, imatinib. So, imatinib was the first TKI changed the course of CML. Now, the mechanism of action of the imatinib, and for that context, all TKIs, with some exceptions, is that they bind to the ATP binding site in the kinase domain, which leads to inhibition of the phosphorylation of the proteins, and the other pathways like the JAK-STAT, the RAS, the PI3K-AKT pathway, they are not activated, and this uncontrolled proliferation is stopped. So the landmark study for imatinib was the IRIS trial in 2001, which we all know, and there's nothing to tell again and again for the same. So it was a phase 3 open label randomized trial, which and imatinib 400 mg once daily was compared with interferon alpha. Now, quickly we're discussing the outcomes at 5 years. Was that when it came to a 5-year complete cytogenetic response, patient who received imatinib at around 87% compared to 35% for the interferon alpha plus low dose Arasi group of patients, and a significant p-value was there definitely. And the rate of progression to the accelerated and blast crisis at that time was also around 7% for imatinib and very high, around 22% for the other group. And the 5-year overall survival was also superior for imatinib group as compared to interferon gamma and low dose Arasi. So the key benefits of imatinib are it's highly selective for the BCR-ABL mutation, and it revolutionized definitely the treatment. High cytogenetic responses and molecular responses were achieved, and there was improvement in the overall and survival as well as the quality of life. So then a 10-year overall survival was also compared, and it was superior for imatinib, 83% here, while 71% for the latter group. And conversion to phase was still again on the lower side for the imatinib group, and a high complete cytogenetic response was also noted. Now, this is important, efficacy against BCR-ABL mutations. So, sensitive mutations for imatinib are M244, E255, and various others like Y253H and E355G as well. While the T315I is the only dreaded mutation that is imatinib destined and destined to many other TKIs. Until now, there are only 2 therapies, ponatinib and asciminib, available that are effective against these mutations. Now then, dasatinib. Dasatinib was a second-generation TKI, powerful, selective, proven, and highly potent. Guys, it was more than 350 times more potent than imatinib against the BCR-ABL fusion mutation. It had superior responses and better outcome. Now, the Dacision trial was the trial that led to its approval, and it was done between imatinib and dasatinib. So at 12 months, the complete cytogenetic response was 77% for the dasatinib arm, while it was 66% for imatinib. When MMR or major molecular response were compared, it was superior for the dasatinib group, which was around 44% compared to 25% for imatinib. Now, MMR median duration to MMR was around 12 months for the dasatinib group, while around 15 months for the imatinib group. And there was a lower transformation rate at 5 years, 4.6 versus 7.3% for imatinib. Now, the only practical aspect, the issue with dasatinib is the cytotoxicity. Besides that, the other one is the accumulation of fluids. Now, we have a common understanding in various centers now. We don't very rarely start with a full dose of 100 mg in chronic phase or 140 mg for in blast phase. There's enough data now that 50 mg is a very good dose with comparable efficacy to standard doses, excellent safety profile, and better adherence. And a 3-month early molecular response of 96% has been found in that data, in the literature. And when we say 12-month major molecular response, it is 81%, and a 5-year overall survival of 96%, and an event-free survival of around 90%. Now, the issues with dasatinib, one is definitely cytotoxicity. The other one is pleural effusion. You see around 25% of patients develop pleural effusion when on dasatinib, and you have to monitor them, clinically examine them, do the chest x-rays in your regular OPD visits. And the other dreaded side effect is pulmonary artery hypertension, which we should look for. So we have already discussed this. So this is from the dasatinib trial. The other point that I want to highlight here is the DEVLEC trial and various other trials like the DEVLEC trial. So it was done by Murray et al. In 2021. They have demonstrated that 50 mg is a very good real world dose, which is 20% of the standard dose, and a comparable efficacy 200 mg, and very less pleural effusion rates around 2%, and was very nicely tolerated in the elderly as well. In addition, they have also told that for severe, very elderly patient, like more than 70 years old, with CMLCP, even a lower dose of 20 mg once daily, which is around less than 10% of the standard dose, an early molecular response was seen in 73% in 3 months, and 12-month median molecular response was seen in 60% of the patients, and pleural effusion of grade 1 2 was seen in only 7.6% of the patients. So it was very nicely tolerated, and so dasatinib in lower doses is very practical as per data as well. In pH positive ALL, definitely we use dasatinib, and the reason is it has got a better blood-brain barrier penetrability. As simple as that. And hence, and we all know that CML and Philadelphia positive ALLs, they are more, liable to, have a CNS involvement by the disease. So various combination with dasatinib is hypersevere BFM, and in myeloid neoplasms, we have with the standard chemotherapy as well. So the other second generation TKI is nilotinib, and the trial was NSTEN trial, and it was a randomized trial. Around 846 patients were there, and nilotinib in a dose of 300 mg twice daily and 400 mg twice daily was compared with imatinib with 400 mg once daily dose. So these are the standard doses for chronic phase: 300 mg twice daily and 400 mg twice daily for the blast phase or acute leukemias with Philadelphia. So key features: they have a faster MMR rate, higher and a better deep molecular response, better survival, and lower progression. So it really did demonstrate a superior cytogenetic response, which was at 24 months about 87% of the patients, and 87 to 85% for both the doses, and as compared to just 77% for imatinib. And we can see definitely the p-value is significant. And enhanced major molecular response was there, which was around at 1 year or 12 months, 44% for 300 mg twice daily and 43% for 400 mg twice daily, as compared to 22% for imatinib. So we can see that it had superior major molecular response rates. Now the side effects. The important side effects to look for with nilotinib are QT prolongation, pancreatitis, rash, hepatotoxicity, and various vascular events. And if we see the various doses with cumulative incidence of vaso-occlusive events was 24.8%, nearly 25% with 300 mg twice daily dose, slightly more, around 33% with the 400 mg twice daily dose, and was very less definitely in imatinib, which was around 6.3% only. So why to choose nilotinib? More responses, deeper control, long-term benefits, and my go-to option in first line if I'm planning for a treatment-free remission. Now, bosutinib, which is also a second generation TKI, it's potent, selective BCR-ABL tyrosine kinase inhibitor, active against most imatinib-resistant mutations except T315I. Once daily dosing is available, unlike nilotinib. So the landmark study was before trial of 2014, where bosutinib 400 mg once daily was compared with imatinib at the same dose. And the overall key points from the study was the higher MMR and cytogenetic responses rates were found, and deeper and faster molecular responses rates were also achieved. So seeing the data, the overall survival, there was not that much significant of a difference. What produced a difference was the efficacy. The MMR rates was 10% more, 47% bosutinib, and 37% in imatinib, although the p-value was not significant. The other point is cytogenetic response was also better, but not significant. Now, why to go for bosutinib? Whenever we have patients with cardiovascular abnormalities or comorbidities, it is a very good drug. The only issue with bosutinib is the GI disturbances, the side effects, diarrhea, nausea, vomiting, bloating. These are much more as compared to other TKIs. So is the hepatotoxicity. And in real world practice, what we do mostly is that we start at a lower dose of 100 to 200 mg once daily and gradually increase to 300 mg once daily. And if the tolerability is good and response is not up to the mark, go up to 400 mg once daily. And this approach is very good. It reduces the GI toxicities. So now moving to the third generation TKI, ponatinib. Now, ponatinib is what was designed to to treat BCR-ABL1 mutated patients with any type of resistance, including T315I. Now, one drug with which you don't need to worry about which mutation it is having is ponatinib. Issues are cost and availability and affordability. So ponatinib binds irreversibly to the ABL kinase domain at the ATP binding site, including in the T315I mutant BCR-ABL1, locking the enzyme and making it inactive, just like the other TKIs. So the landmark trial that led to its approval was the PACE trial. That introduced ponatinib in the practice of CML was the PACE trial, and it was a phase 2 single-arm study. And around 267 patients were there, and a dose of 45 mg once daily was used, and it was reduced to 15 mg when complete cytogenetic response was achieved for at least 2 years. Now, what they found in the study was that MMR, the major cytogenetic response at 12 months was around 54%, while a complete cytogenetic response at 12 months was seen in 31% of the patients. Now, following it, a randomized trial was conducted, which was the OPTIC trial. Now, this trial compared ponatinib with imatinib upfront in all the cases of CML, CP, with the patients of around 307, and ponatinib was also evaluated in various dosages, like in 15 mg only, 30 mg, and 45 mg, and compared with these three doses with the imatinib of 400 mg once daily dose. So the key features that they found was that at 12 months, ponatinib had superior and major molecular responses, which was 64% as compared to 32% in imatinib, and with a very significant p-value, and 12-month complete cytogenetic response rate about 80%. So in the PACE study, patients with T315I mutations were generally younger. Okay, so it is not like they are having multiple therapies. Many of them were younger patients with early detected T315I mutation, so they have responded very nicely. So there's a rider for it. Now, more recently diagnosed and treated with very less prior TKIs. So that is a slightly point that we face, because majority of the times when we give or go for ponatinib, it is very commonly a 2 or more than 2 line TKI failure. Now, seeing the data of OPTIC trial at various doses of 15, 30, and 45, you can just see the MMR rates were superior to imatinib, which was around 5, 9, and 9, right? And at 12 months, the complete cytogenetic response rate is also around 96% as compared to 93% for imatinib. And the only issue were the vaso-occlusive events that were very high, around 9%, with a higher dose of 45 mg, which is very significant in clinical practice. Now, the dosing that they suggested was you start at 45 mg once daily and gradually reduce to 15 mg once you reach your molecular targets. Although this is very good to look at, but when you come to practice, it's very difficult. And majority of the patients that we treat do have various comorbidities. So in a practical point of view, many centers, they start at a 30 mg dose, gradually increase to 45 mg or even at 15 mg initial dose given the comorbidity status of the patients and gradually increase as per tolerability. Now, the common adverse events are hypertension, rash, elevated this pancreatitis, headache, fatigue, and thrombocytopenia and bone marrow suppression. Now, the historic impact that ponatinib had basically was it was a hope for patients with T315I mutation, which was considered as a previously untreatable population. Now, coming to the wonder drug asciminib, which is the first and only STAMP inhibitor. STAMP stands for specifically targeting the ABL merisstoid pocket. Now, it was the assembled trial that led to the approval of asciminib and introduced asciminib in the practice. So it was a randomized trial in 2:1 ratio for asciminib and bosutinib arms, and 233 patients were enrolled, while asciminib was given at a dose of 40 mg twice daily, while bosutinib was given as dose of 500 mg. Now, the primary endpoint was MMR at 24 weeks, while the second endpoint was MMR at 96 weeks. Other endpoints were complete cytogenetic response, PS and OS. So at 96 weeks, we can see for asciminib at a dose of 40 mg twice daily, MMR rate was 53.5% as compared to bosutinib, which was around 20%, less than 20%. And the MR 4.5 rates was 17.2%, which was 10.5 for bosutinib. And so all of the rates, be it complete cytogenetic response rates, were also superior for asciminib. But in this point, when I'm using or when we are using asciminib, this point, BCR-ABL1 IS scale less than 1% is very much practical value, as at that point, when we have disease that is destined to not responding to 2-3 lines of TKI, even this response is more than enough to sustain life of the patient. So safety summary for the patient, the adverse events in asciminib were comparable to bosutinib, and adverse events leading to discontinuation of asciminib was very low, around 7% in asciminib arm compared to 25% in bosutinib. So the major adverse events are as per the frequency: thrombocytopenia, neutropenia, that is cytotoxicity, followed by diarrhea and vaso-occlusive events. So the takeaway point is most potent TKI active against all BCR-ABL1 mutations, including T315. Amongst them, besides ponatinib, is asciminib, and high response rates are seen in resistant and intolerant CML patients. Superior molecular and cytogenetic responses were seen in versus imatinib as well. So caution is there is risk of arterial occlusive events slightly less than ponatinib. Those escalation strategies should be employed here as well. Now what happens in asciminib? It is binding to an allosteric site, not to the ATP binding site. So what that has led, the various studies are being conducted for seeing combination of asciminib with various other TKIs and seeing the synergistic action of these two TKIs together in specifically this cohort where we have resistant disease or a refractory disease. And the data of which is very exciting and is awaited to come in the guidelines. Now, this is the summary of how should we approach. Now, coming to the, before ending, the final few slides on the milestones. So the guidelines suggest milestones at 3 months should be less than equal to 10%. And this corresponds to the major cytogenetic response. So at 3 months, at 6 months, it should be less than 1%. At the end of a year of therapy, it should be less than 0.1%. And this corresponds to the major molecular response. While at 24 months and beyond, it should be less than 0.01%, which is the deep molecular response. And if it is less than 0.0032%, it is called MR 4.5. Now, this very good paper by Dr. Jijitsu Senapati et al. In 2023 came, where a common ground and common sense-based practice for CML was being discussed. What they highlighted here was that due to various factors like, the cost constraints, the affordability, and the quality of life on a long term does not get severely impaired if you have an IS scale less than no 0.01% at 12 months. What they said in the study was that milestones like the IS of 10% at 3 months is fine, but at 6, 12, at 6 and 12 both, a cutoff of 1% is also very significant cutoff clinically, and at 18 months and beyond, a 0.1% MR cutoff is significant, while a 0.01% is significant at the end of 3 to 5 years when we plan for a TFR. So this stringent, alignment to, an IS of less than 0.01%, changing the TKI just to achieve a deep molecular response is good when you plan for a TFR. If TFR is not your aim, then this practical guideline of keeping it less than 1% is also very significant, specifically in practice to India, but that varies from center to center and the type of patient you are treating. So why this matter? We have told the central idea is TFR. TFR is the central point to decide these things, followed by toxicity and cost effectiveness. Is the disease progressive? We can come to know with the mutations as well. So final point that we should know that we should, when we select a TKI, the comorbidity status should be in thorough, available to the clinician, because if the patient is diabetic, nilotinib is not a good option. If you have pulmonary disease or pulmonary artery hypertension, dasatinib is not a good option. If you have GI issues, bosutinib is definitely not a good option. Imatinib is slightly tolerable, but still has GI issues. If you have cardiovascular issues, you should avoid nilotinib and dasatinib. If peripheral vascular disease, nilotinib should be avoided. It deranges the lipid profile and various other side effects. If liver is the issue, bosutinib should be avoided. And if you have renal issues, imatinib and bosutinib should be avoided. Now, we have already discussed how to select the frontline therapy and the side effects of various drugs. So, various other studies going on. One is the Topaz study with multiple line therapy, including T315I mutated patients are being studied, and various drugs like vidobatinib, olverembatinib are also being studied, and phase 1 studies have already started, and these are evaluating for patients with 3-line failure and as well as T315I mutated patients. Now, the concept of TFR or treatment-free remission, it means basically when can we stop treatment and just keep the patient on follow-up. Now, remember one thing, not everyone is a candidate for TFR. It should fulfill certain criteria, like you should be able to pick up a patient in a CP phase or clonic phase only. There should not be history of accelerated phase or blast phase. It should be having a P210 transcript, because that is the only transcript you can monitor on a quantitative PCR. At least 5 years of TKI therapy should be given with one of the TKIs, and deep molecular response in these 5 years should be for at least greater than equal to 2 years. And the patient should be compliant. The most important thing in practice, the patient should be compliant, and reliable PCR testing facility should be available. So various studies have been conducted which suggest with various TKIs, TFR is possible. And it is very good with second generation TKIs. And our experience with nilotinib has been very good. But various centers have had good experience with dasatinib as well as bosutinib, which are comparable and very good. So why TFR? It is basically for the patient-centered decision, aiming for a better quality of life and less hospital visits for the patient. Now, management of blast crisis needs a separate session at all. We can discuss it on a separate CME. Now, before ending, I wanted to end on a very important note that this is a time of precision medicine, and we have enough data now that there are certain mutations in CML that have a high risk of chance of progression to the accelerated phase. Now, just we can say chance of progression to a blast phase. Now, this is a table that shows various mutations and the risk of progression that they come by, which is the TP53 having the maximum around 40 to 60%. Now, this ESXL1 we have seen many times in our practice. It has around, which is epigenetic mutation, has around 30 to 45% risk of progression, followed by RUNX1, Icaros, Zinc-finger1, IKZF1, TET2, DNMT3, and so on. So in cytogenetic abnormalities, trisomy 8, extra additional filled alpha chromosome, isochromosome 17q, deletion 7, and 3q abnormalities are also associated with early progression. Now, why is it important? This is important because a precision medicine-based model, and we can tailor the treatment initially. As in low risk profile, we can continue with the standard TKIs. In the intermediate risk and high profile, we can use second line and third line TKIs. And in conditions like T315I mutated patients, we can go for a upfront transplant as well. So the key takeaway message points is CML classification is now only chronic and blast phase. TKI therapies forms the backbone. Newer TKIs, DASA, Nilo, bosutinib, ponatinib are good players in the game, and now asciminib has joined all of them. Now, low dose of TKI are good options, equally efficacious, and therapy should be tailored as per the patient. TFR in eligible patients should be tried. Choice of TKI still depends on the patient's decision, physician's assessment of the patient, and are we able to do response assessment or not on a time-to-time basis. For T315I mutation, ponatinib and asciminib are good options. And for TFR, yes. So TFR monitoring, it's important. How to monitor? In the first 6 months, you do a monthly monitoring, followed by once in 3 months for the next 6 months. Then for the whole life, once in 3 months. And when do you start a TKI? When the patient is already stopped on drug. Whenever there's loss of major molecular response, that is IS becomes more than 0.1%, you restart TKI again. And these patients do very well and they maintain the major molecular response when restarted on TKI. We should look for prognostic factors like ASXL1, IKZF1, MECOM, and all. These are associated with poor prognosis, and early transplant can be considered for them. And so it's important on the closure, diagnose as which phase, start the therapy, optimize it, tailor it as per the patient, monitor, consider TFR in eligible patients, manage the relapse and progression, consider transplant whenever necessary. I thank you everyone, and I hand over to Team IAIO for the next session.
Thank you, sir. Moving from theory to clinical practice, we now begin our panel discussion, CML real-world case and evolving therapeutic approach. I would like to introduce our moderator, Dr. Satrupa Mahapatra, consultant hemato-oncologist, Bakshi Sri Shankara Cancer Center and Research Institute, Bhubaneswar. Joining her are our esteemed panelists, Dr. Jay Juvikar, consultant clinical hematologist and hemato-oncologist, say GS Medical College and Kim Hospital, Mumbai; Dr. Gopinathan M., consultant hemato-oncologist and bone marrow transplant, BGM Cancer Institute, Chennai; Dr. Shilpa Gupta, hemato-oncologist and cellular therapy specialist, Holy Spirit Hospital, Mumbai. I hand it over to our moderator, Dr. Satrupa Mahapatra, to lead this fine expert exchange. Over to you, ma'am.
Hi, good evening, everyone. Good evening to all the participants and to my panelists and to Dr. Tushar for giving me this opportunity to moderate this panel. So unfortunately, we don't have Dr. Shilpa Gupta with us today. So it'll be just Dr. Jai Juvekar and Dr. Gopinathan. So I'll just share my screen. Give me 2 minutes. Can I share? I think it will be better if I share from my side.
Okay, ma'am.
So my screen, is my screen okay, visible to everyone?
Yes, ma'am.
Yeah. Okay, so we'll discuss a real world case. So, Dr. Tushar has actually provided the ideal background for my discussion today. And we'll be addressing some of these issues, and common issues that, we face in our everyday clinical practice, every day that we sit in front of the patient. So we have a 32-year-old male who was diagnosed in February 2022. He presented with a 3-month history of fatigue, easy bruising, pedal edema, initially evaluated locally and was found to have a high white cell count and platelets. Family history, he has a history of CAD in the father, and he does not personally have any comorbidities. So these are the baseline lab parameters. As you can see, hemoglobin was 9, the WBC was quite elevated, platelets marginally elevated. And you could see, like, if you looked at the differential and the PS, there was marked leukocytosis with left shift, with eosinophilia, basophilia, and blasts around 5%. The peripheral blood fish was positive for BCR-ABL. The bone marrow aspiration was done. It was a dry tap. Bone marrow biopsy showed that he was a CML in CP. Now, the BCR-ABL burden was 82%, and cytogenetics also showed our PH chromosome. So I think there's just two of you, and whoever can go forward and
Right.
answer. Yeah.
Right.
So, first question, what is your initial approach to confirming CML diagnosis and risk stratifying this patient? Anyone?
Is it okay if I go first, Dr. Gopinathan?
Yeah, please.
Yes, yes. So my approach, once I do suspect a CML, so then I do a FISH for diagnosing T922. I do a CK for the same as well as confirming the advanced cytogenetic changes, abnormalities. And with that, I do a baseline RT-PCR for the transcript which I have to be targeting later on. Risk stratifying, I usually go for the ELTS score for risk stratifying the patient.
Okay.
Okay, anything else, Dr. Gopi, you'd like to add?
First of all, as like in continuation with what Dr. Jay had said, so obviously peripheral smear, in addition to T922, will also get a karyotyping done, just in case not to miss anything. And quantitative PCR these days I'm doing because some patients we do not know the baseline load of BCR-ABL IS percentage. So something that I can keep as a trajectory for the response follow-up at 3 months and 6 months. So that is something I'm doing extra. And scoring system per se, at this point of time, I'm following ELTS score mainly for the response prediction. And would you do NGS at baseline at this point of time? But baseline I'm not doing because we may not even pick up if we do something, maybe if the disease gets selected later on. So at this point of even since we don't have any actionable treatment at this point of time, I'm not doing it currently.
And for all our tests, like for karyotyping and for FISH and for PCR, any preference between a bone marrow sample or a peripheral blood sample?
Yeah, so if had the case scenario that what you had typically projected with high counts, good amount of blast, typically peripheral blood smear is used. Mostly I don't do bone marrow when we have a clear telltale picture on the peripheral smear per se. But if you have some vague patient with some kind of skin manifestation, some unusual bone pains, some kind of lymph nodes, in those patients, I'm really getting a bone marrow aspirate and biopsy. Otherwise, I'm not getting a bone marrow aspirate and biopsy.
What about you, Dr. Jay? So do you do in every
So
patient?
yes, so bone marrow only when I'm going to send a conventional karyotype. So that time I do a bone marrow and send my samples from the bone marrow for CK. Although peripheral blood can also get a good CK, but I would prefer doing a bone marrow and sending it.
Okay, yeah. So I think that's most of us how we practice. I personally I do a bone marrow for every patient again to send cytogenetic and just to confirm that the patient is not in an accelerated phase or a blast phase, which we'll discuss. So these are like the ELN guidelines, the ELN 2025 guidelines, and it's just concurrent with our everyday practice, like FISH, your cytogenetics. And so you have to look at the additional chromosomal abnormalities, and that's why cytogenetics is important. And also, as we know, we all do an RT-PCR and a quantitative PCR, like even I am doing for all my patients. However, current guidelines, they do not, favor doing it for all patients. And so the next question was posed in CML. Now Dr. Tushar also discussed it, and ELTS is definitely superior now, and it is a good predictor of survival of CML specific survival. And in our routine practice, and even on the guidelines, we have moved towards ELTS to decide our treatment. Again, the CML, I think this is something that I believe is evolving. Would you agree, like Dr. Gopi and Dr. Like we don't have, like, not right now, but sometime in the future we may have to even do an NGS at baseline.
Yeah.
And here, yeah, please go ahead. Yes.
I can just come across a paper recently that one of our colleague from Chennai shared, Dr. Kishore. I think he is doing baseline myeloid NGS for most of his CML patients, and he has just put a kind of a food for thought, a time to rethink. But at this point of time, since we all practice single TKI, but maybe in the future we may have double TKIs in use, or TKI plus some other targeted agent. Either like I can come across some preclinical studies like Jakavi, something like an inhibitor, IDH inhibitor, EZH2 inhibitor. So these are all just in preclinical trials. Maybe moving forward, we may have such data and such guidelines to respond. But as I said, when we are just failing one TKA and we're moving to second TKA, that is the time I'm doing currently.
Okay, so even even in a case of even if the patient is in CP, if you are failing a TKI, you are going ahead with an.
Yes.
Okay, that is good. So what does this guideline, the CLN recent guideline suggests? So it does acknowledge like that somatically mutated genes are found in CML and more frequently in advanced phase than chronic phase disease. Detection not routinely indicated at diagnosis in CP. So recommended in blast phase. But then again, the same thing that we have just discovered, that what to do with a mutation, how to act on it. So again, food for thought, as Dr. Gopi said. So, how do you decide on first line therapy?
I think it's a clear-cut exam answer. So it's a ELTS scoring that we do, low
Yeah.
risk, intermediate, and high. And obviously, somebody with a ELTS low score, still, since imatinib has got a very good long-term data, though I know that we have multiple, new kids on the block and most fashionable kids on the block, still I stick to imatinib in clinical practice because we know how well to manage imatinib toxicities. We know how well to play with the drug. So still I give imatinib in low and intermediate risk patients, but for high risk, uh, I kind of prefer a second line TK, provided that patient that we are seeing doesn't have any comorbidities which can influence the adverse effects or toxicities. That is the way that I deal with first line therapy. Yeah, maybe Dr. J, you want to take the second question?
Yes. So my decision on how I decide for the first line, first would be the goal of therapy. If it is TFR or if it is just overall survival. After that, I go for age. Again, if it's an elderly age, then I would, even if it's, then again, I would still prefer imatinib to a second generation. But if I am going for a TFR, and if the patient is not elderly, I think irrespective of the score, I would still go for a second generation TKI upfront.
And among the TKI second generation, like, okay, we have to keep in mind the comorbidities, but
Yes.
but what is your go-to? Like Dr. Tushar said, his was his nilotinib. What is your go-to?
Right. So my go-to, madam, is dasatinib, and I usually start with a 50 mg dose because trials, not phase three randomized control trials, but phase two trials have shown that they're fairly equivalent. The responses are pretty good. So I usually start with dasatinib, 50 mg upfront.
What about you, Dr. Gopi?
My choice is dasatinib. Somehow I'm not very comfortable using nilotinib because
Yeah.
of twice
Right.
daily dosing and
Yeah,
a lot
me
of
too. I
food
agree. Yeah.
interactions. Food interactions.
You go for
Of
long.
yeah, of late somehow I'm developing attraction towards bosutinib.
Mhm.
Because if at all the patient tolerates without any GI side effects, it's a really wonderful drug and no much of
Mhm.
cytopenias, no not much of cardiorespiratory toxicity. So kind of now I have a balanced pool of both DASA patients on both DASA as well as bosutinib. Nilotinib is totally forgotten. I mean, almost I would say it's less than 1%. This is my preferred second line TKs, and I start with 70 actually. So I take weight as a cutoff, so less than 40 and more than 40. But to somebody who's less than 40, then I do 50 milligram OD. But otherwise, I usually start with 70 milligram OD. If somebody is well built and kind of 90 to 100 kilograms and all, so for them, I start with still 100 and titrate based on the second week cytopenia.
Okay, so yeah, so most of us kind of start with around 50, 70, and then go up to 100. Yeah, next question is again a debate. What is your take on accelerated phase in CML now that WHO has thrown it off, and and a lot of a lot of experts don't really agree with the WHO doing that. So how do you label, like, if this patient had a blast of like say 15%, 16%, so what would be your approach?
So yes, accelerated phase is something in between. So a de novo accelerated phase is still okay. I would still consider giving it a second generation TKI, but I would really be vigilant about the responses of whether the patient is getting the proper milestones or no. While if there's an accelerated phase on a TKI, that alerts me that this patient is going to go into a blast crisis, and I would simultaneously go for transplant.
Yeah.
So this is a subset of patient which I would also be very careful with, and this is a patient whom I never miss doing a bone marrow aspiration and biopsy. So if you're having very low blast count, obviously we can skip for our own practical logistical reasons, but this is a patient definitely bone marrow aspiration biopsy is indicated. And maybe even if your pathologist is doubting some kind of, the blast count and all, then better to put an IHC and confirm and preserve samples for, kind of preserve the DNA and keep for, if at all you need to perform any analysis further. Second thing is for this patients, I'm using second line TK upfront. So I'm using dasatinib for most of
And
it.
at what dose?
I'm using 100 for these patients.
Yeah, and this group can. Oh, yes, Dr. Tushar, please.
Any comments on if it's a lymphoid blast accelerated phase? So any difference?
Lymphoid blast?
But there has been data that if the lymphoid blast even a 5 to 6%, if the percentage is low, still if it's a lymphoid blast, treatment like a blast phase can be considered. So I wanted to know the views of our panelists for the same, if it is a situation that.
So yes, the WHO does say that even if you consider, even if there's an accelerated phase, but the blasts are lymphoid, you treat them as blast phase only because they are eventually going to go into a blast phase. Yes, so I would really be vigilant. And again, as I said, if the patient does progress or does not attain milestone, I would go ahead with evaluating for transplant together simultaneously with treating him.
What about you, Dr. Gopi?
Yeah, I would kind of stick on to the same guideline. Something I didn't phase across till now, but
Yeah.
eventually this will eventually the biology seems to be because why a lymphoid blast in a typical myeloid disorder. So
Yes.
definitely it will eventually progress to that stage.
Yeah. Okay, so as Dr. Tushar has discussed, first-line therapy depends on our treatment goal, the age of the patient, our risk stratification, comorbidities, medication cost, which of course has come down because of our generics and patient preference. So this is how, WHO had the CP, AP, BP, then you have ICC, and then now WHO has removed the accelerated phase and has given this, high risk indicators at diagnosis, like high ELTS score, blast 10 to 99, all of that was accelerated phase has now kind of moved to high risk indicators. And but the ELN kind of still sticks to that. They still believe that it's important. And I was reading up like this is a good commentary on CML and the WHO. Why very useful commentary. And these experts tell that even if it's a de novo AP, it's still worse than CP. So it's not the same disease. And then de novo AP versus progression to AP, as Dr. Jayesh said, that progression is much worse. The outcomes when somebody progresses to AP is much worse than those presenting with de novo AP. Now, presence of cytogenetic lesions like 3Q26 or MECOM, they tell that it's significantly inferior survival and you cannot treat them like CP. And then this dose of drugs, because previously the dose like for dasatinib it was like 140 milligrams, and now we are giving them 100 milligrams. So all of this, they really they did not like this this team, and even in the ELN paper they really don't approve of WHO kicking it off. So back to our patient, Sokal intermediate risk 1.06. So this should not be used. It should have been ELTS. And then started on imatinib 400 milligram in February 2022. Now 3 months, it's around 12%, a little bit off our threshold. And then in July 2022, the patient begins to have a thrombocytopenia. So how do you manage his patients? Like, I think it's fair common. Like I do encounter trouble, and I like every one of us. How do you manage such patients with imatinib-induced cytopenias?
So up until if it is just a grade 2, grade 3 cytopenia, we can manage them with weekly growth factors. So obviously that's what I think all of us keep doing. We do some degree of erythropoietin. We do nuclein twice or thrice a day. We do romiplastim, and then try and push the adequate dose of TKI to exert the maximum clinical efficacy. But if it is really troublesome managing them, if they are just entering the borderline grade 4 cytopenia, then at that time we need to really consider dose reduction, or if there is any hospitalization, we may need to transiently stop TKI for a while and then reinitiate when the absolute clinical toxicity recovers. So that's what I keep doing. And very rarely, say for example, if it is imatinib or something like dasatinib that I'm using, then I slightly consider shifting to a non-toxic TK like non-marotoxic TK like Positive.
Yeah, so that's what, so imatinib-induced cytopenia with dose reduction, dose interruptions, addition of growth factor support. So sorry, I should have put this ahead. I'll go back. So now imatinib was on hold for 1 month in July 2022. So May kind of you see in July platelets are low, in August platelets are low. So imatinib was stopped and then restarted with 200 milligram once a daily in August 2022. And now you can see like around September, which is the 6 months mark, our BCR-ABL has risen to 22%. So this brings me to back to my question: what to do? What do you do now?
Right. So when if your BCR ABL is more than 10 at 3 months, it is still, it's in between. It's the warning one,
Yeah.
but it's not an indication to change therapy, right?
Yes,
But
exactly.
definitely yeah, so definitely it has to be monitored more properly. But at 6 months, if your BCR ABL is more than 10%, then definitely you think that the patient is going to be resistant to imatinib. In that case, what you do next is to definitely do a TKD mutation analysis. And depending on the mutation analysis and the comorbidities, think of your second generation TKI. In this case, she is 32. I would start with dasatinib for her.
Yeah. Dr. Gopi, do you agree? Like,
Yeah, almost. I mean, as per guidelines and I think practical points, it is really an apt answer. But what I would slightly think in her case, I think you projected the baseline BCR-ABL was 82%.
yeah, 82. Yeah.
So this is really not such a bad figure. 12 is really not a bad figure. I would kind of continue for 3 more months and then see at 6 months what is it. And if I'm able to really reach the somewhere close figure, even 3-4, I'm kind of quite happy. Still, we have 3-4 months time to attain that less than 1%.
Yeah.
Mhm.
So, this has, like Dr. Gopi said, it's kind of a little bit different now. Like previously, ELN used to categorize favorable warning and like failure kind of a thing. Now they have given this category as unfavorable, in which, of course, when you're at 3 months, I think at 10%, none of us will, change. And maybe at 6 months, depending on what it is, how it is, some of us may really decide to change or wait a little bit and see whatever. So the patient was at this level, patient was initiated on dasatinib. We did not do a TKD mutation at this point of time. Patient was started on dasatinib 100 milligrams from September 2022. Now, again, with initiation of dasatinib, the counts drop, platelets drop to 57, 43, and all of that. So we had to dose reduce dasatinib to 50 milligram OD till July 2023. And it was then now in July 2023, when you see the BCR-ABL, now this March 2023 patient is 1 year and it's still at a BCR-ABL IS of 8.6%. Now, because of all these, due to those reductions and whatever be the reason, July 2023, the BCR-ABL is now 10 point, it is almost a year above diagnosis and it is 10.3%. Now, patient is fully compliant to treatment, everything's good. Then let's see what's next. Just a minute. Sorry. So it was nevertheless because there was we decided to because there was some sort of response, because it was on 50, we decided to increase it to 100 and thereby it was continued. Now October 2023 it was again around 3.97%, January 2024 4.5%. And March 2024, now the patient is 2 years post-diagnosis. Still, patient is not in like a complete cytogenetic response. Now, this was when the patient was convinced and we had to do a mutation analysis. There was no mutation. The marrow did not show any signs of progression. So now we thought about consideration of alloSCT and consideration of ponatinib versus asciminib. So then the patient was switched to asciminib in August 2024, and siblings are all haploidentical. And you can see that even with asciminib, the patient still has like a BCR-ABL, like there's no major cytogenetic response. So this brings me to my question. So asciminib versus ponatinib in a multi-resistant CMLCP patient. So for a third line patient, now the patient does not have a TKD mutation failing dasatinib, and how will we choose? I think this is the hottest debate right now, asciminib versus ponatinib. And how do you think, like, what would you have done in this case? 2 years, with second generation TKI patient does not have a cytogenetic remission.
But since if at all the patient would have had a T315I, definitely I would have pushed for ponatinib. That is what I would have done. But if not T315I, I think still asciminib is a good choice. So that is what I would do. And obviously we know because TKA has to be continued at least if we start today, it is for the next 3 to 5 years, definitely it is going to be there. So I will reasonably choose safer non-toxic TKI. So had here, only thing that will influence me is T315I. I think that we have a recent publication also from the Gerber's paper, Sir's paper is there, I think. So that we can quote and we can still use asciminib if there is no T315I.
Anything, Dr. Jay, that you would add?
No, I agree. So if there's T315I, I would prefer ponatinib. Rest, asciminib would be better. Yes. In
Yeah, and
terms of efficacy, safety, both, and
yes,
even the vascular risk factors, asciminib
yeah,
would be better.
yes. So there was we don't have like head-to-head comparison, but as I think the paper that Dr. Gopi was referring to was like a matched analysis. It was an indirect comparison, and in that case, even without a T315I, ponatinib kind of did better. So for everything. But here, then we have to think about risk of cardiovascular events, cost, and all of that. And that because ponatinib is a fairly toxic drug, and that's why we would prefer asciminib. Now, as I said, the patient even on asciminib was switched to asciminib in August 2024, and you can see October 2024, Jan 2024, and continuing still has like no cytogenetic response. So what would you do? So how do you manage asciminib refractory CMLCP? What would you do? Will you jump to what next?
So is it we do have a myeloid NGS data at this point of time because it's almost 2 TKAs that is that's over. And I think one of your slides showed monosomy. I mean, why is it some additional?
Yeah. This was a monosomy Y here in around, yeah.
Right. So I'll be interested to really look at the data of myeloid NGS at this point of time. That is number one. And number two, I had one more doubt with your patient. I think when we started dasatinib, you started with 100, if I believe. Maybe what I would have done is I would have started with 50 and then gone back to 100. Partly, I think the patient is not tolerating the therapy also. The cause for BCR-ABL rise, I feel it's probably we are not able to give that full, sustained dose related inhibition for the disease. So what I would do is I'd be more interested in getting a myeloid NGS at this point of time. And if at all, obviously I'd check out a marrow if there are no increased blast and per se with already, and since she is already on a third line TKI, this patient would be an ideal candidate for consolidation with allo because it's almost already third line right now, and TKA induced toxicities are going to be there. Invariably her marrow stroma is going to get damaged day by day, and she's going to have with this just 2 TKA and that too not at not even a full dose. She's having such a marrow toxicity, and eventually she's going to turn out hypocellular.
Yeah, so we would we would consider for an allo, and she's young, so
Right.
if she was older, maybe a 2% and a patient not progressing would have been still acceptable, but she's a young patient. So any role, actually, there's no data, I think. So there's no data. There's nothing on what to do. Whether a dose escalation of asciminib would help. If you give a dose that is required for T315, I don't know. A switch to ponatinib from asciminib, I not really, right?
For
Yeah.
how long?
Yeah,
I
yeah.
think we can just expose her to even more,
Mm,
Right,
at least up until a period of 1 year. Though on asciminib, this reduction, so the early TFR is what is a better advantage with most of this, the non-stamp inhibitor is what they say. So the kinetic should be even more robust. But this patient is, slightly not following that kinetics.
In combination, again, we don't have data. It's evolving.
very early.
Yeah. So, and now we have the role of, I think each of us agree that we'll have some, transplant is something that we would really consider. So again, just a standard question, role of allo-SCT in the TKI area, and with haplodonors, would you proceed or transplant? Or I think we've discussed this. We would do not know, no more TKI, no more
No more
toxicity.
detail.
Yeah,
She is young, she's 32, she is
yeah,
fit,
yeah,
and there have been three very good drugs which she has been exposed to, and the CML is not responding, you would haplo her.
yeah. Okay. And again, so role of this is one patient where you would consider allo-SCT, other the few indications, and we can stop any. You can just tell a few indications where you would consider.
So as we were just discussing, any drug, any patient on third line TKA, particularly in a country like us where you don't know how much after the third line, the third line drugs are at this point of time are more expensive, rather than for that actually we can consider allo transplant. And second, blast crisis is a known indication, and somebody
Yep.
with a high risk mutation like T195 there is a role for allo transplant. And obviously, since the haplotransplant platforms have considerably improved, we don't even need to do a math with this lady, I feel. Even a RIC platform would be okay to do a haplo on her. So, so these are some of the indications, and this is what we would do at this point of time.
Yeah. So this is like a fairly this is from one of the ASH education book, and I like it's still relevant. This is a little older, but I think this is a very good table, and it shows the indications kind of are still quite relevant. So that's all from my side. We have a question, so we can answer. When it's warning phase with imatinib during first 6 months, role of increasing the dose of imatinib to 600 milligrams.
So, I mean, there was a hot debate even on this particular question the last week's seminar. So, current era, we are not supposed to do this, rising imatinib to 600 milligram. So, we would just continue with 400. And if it is still not following an optimal milestone, you have to switch to a second line TK. So, we are not really backed up by a strong evidence at this time point in 2026.
Yeah, exactly. So whatever we have stays, like switch a TKI.
Which agree.
Yeah. Okay, so that's it. And I hand over to the organizers.
Well, thank you, Dr. Satrupa. Great session conducted by you. So, and thank you to our esteemed panelists, Dr. Jay and Dr. Gopinath. Thank you so much for your valuable insights. I think it was a very enriching session for everyone, all of us as well as all the attendees. So thank you so much for your insights, and thank you to the team IAIO for arranging this and bringing all of us together with our busy OPDs and rounds.
Yeah.
So thank you to the team, and
Thank you, everyone.
Thank you. It was always a good learning, talking to people, learning from their experiences. Yeah.
So felt so happy after meeting
yes,
such
and
a
I
good
get to meet
crowd.
everyone through this. Again, we all are so
Yeah.
busy. We're just
Yes.
planning to go to MHG and everything. We don't get the time now, like before.
Please come to ISBMT. It's an actor. It's in Mumbai.
Definitely. Thank you, Dr. Jay.
Sir, I think there is one question from Dr. Shaksham Singh, if I'm not wrong.
Well, we covered
Yeah,
that.
Yeah.
We covered that.
it's covered.
Thank you, sir.
Okay, I guess before moving, I just one more question that I wanted to ask. So, what's your policy of using ponatinib? Like the guidelines say 45, 30, then 50. So, how do you titrate the doses? Do you prefer starting at 15, going to 30, or starting at 30 and then taking the to the other sides?
Yes. So Dr. Tushar, I usually start at 15
Yes.
again because they do not really tolerate, and we'll have to just monitor because these patients are going to be exposed to a lot of TKIs and they don't really tolerate that well. So I start with 15, try to escalate to 45 if they tolerate well.
Yeah, same with me. This is very, yeah, trouble tolerating nilotinib. Yeah.
Thank you. So, I think we can hand over to team IAIO and we can proceed to the third session and you can start.
Thank you.
Okay.
Thank you,
Thank
everyone.
you.
Thank you, sir. Moving to our final session focuses on IO centered patient blood management, defining unavoidable transfusion and timing derbipotin alpha to protect ICI efficacy. Please welcome Dr. Saksham Singh, Assistant Professor, Department of Medical Oncology at Dr. Ram Manohar Lohia, Institute of Medical Sciences, Lucknow, to share his insights. Over to you, sir.
So hello, am I audible?
Yes, sir.
Can I have my slide?
Yes, sir.
Sir, 2 more minutes, sir. We'll share the
Yeah,
slides.
I can. Yeah. What? Hello?
We will share the
Sir,
slides early,
two.
sir.
We will share you these slides, sir. Give me 2 minutes of time.
Any problem in sharing the slides? Should I send it to you?
One minute, sir. We are trying.
Yes, so hello everyone. I would like to request the organizers to help me with the slide movement.
Yes, sir.
Yeah, okay. So I'm going to present a chemotherapy-induced anemia and the role of darbepoetin alpha in chemotherapy-induced anemia. Next slide. So, what can be the possible etiologies for cancer-related anemia? So, a cancer-related anemia can be because of chemotherapy-induced anemia, means because of response to chemotherapy, or it can be anemia secondary to the underlying cancer itself, or it can be multisystemic problem. Suppose a patient is having chronic kidney disease in cancer. So, chemotherapy in itself can cause myelosuppression, and sometimes chemotherapy causes thrombocytopenia, and because of that patient gets blood loss and then the patient gets anemia. So the first etiology is more common, that chemotherapy in itself because of myelosuppression causes anemia. Then generally there are cancers which because of their nature cause anemia. For example, we have bone marrow involvement because of the cancer itself, or generally because cancer is a chronic inflammatory situation within the body, it causes functional iron deficiency. We have some hematological malignancies which involve the bone marrow itself, for example, myelodysplastic syndrome. Then we have pure red cell aplasia also. Sometimes cancer cells, they cause hemolysis or hemophagocytosis, and sometimes because of treatment related to cancer, for example, frequent phlebotomy, or sometimes because of solid cancers involving GI, GI anastomotic situations. They cause GI bleeding, and because of that, anemia happens. So many times, a patient with cancer is having chronic kidney disease also, and because of primary chronic kidney disease, patient presents with anemia, or sometimes because of cancer involvement, the patient's kidney gets involved, and there is low erythropoietin production, which causes anemia. Next slide. So why cancer-induced anemia is a silent burden? It is a silent burden because overall treatment with chemotherapy, or overall because of cancer itself, as it is an inflammatory situation, the patient is having a chronic fatigue. Generally, they complain like they are having fatigue, and they lose appetite. It's very common, complaint which a patient comes with, that they are having this unnecessary fatigue, or they have lost the appetite. And because of the whole situation, they generally feel unhappy, their cognitive performance declines. So the symptomatic burden is quite high in such patients. They feel fatigued, they have impaired cognitive function. Then overall, the anemia in itself may cause respiratory comorbidities, or may aggravate the respiratory comorbidities, or may aggravate the cardiovascular comorbidities. Overall, because of frequent anemia, patient would be having poor performance status, and because of that, sometimes we have to interrupt the chemotherapy, and that's why patients chemotherapy cycles get delayed. Sometimes we have to decrease the dose of chemotherapy because the patient complains of poor performance, and then it's not right to or appropriate to give full 100% chemotherapy. So either cycles get interrupted or the doses get reduced. Ultimately, the patient's response to chemotherapy gets dampened, and then this leads to poorer outcomes. Next slide. So, how to diagnose this cancer-induced anemia? So, we have this CTCAE version 5 or WHO grading criteria, we can keep it like less than 8, 8 to 10, more than 10 means 10 to 12. So less than 8, 8 to 10 or 10 to 12. And the anemia grade will be grade 3 for less than 7.9, grade 2 for 8 to 9.9, and grade 1 for 10 to 11.9. Grade 4 will be life-threatening consequences requiring urgent interventions. So overall, the rule is it is a diagnosis of exclusion, and trigger should be hemoglobin less than 11 or drop of 2 gram per deciliter from the last hemoglobin level. Initially, like a general hematological evaluation,
Sorry, sir, we are unable to hear your voice.
next.
Sir, I think you are facing some network issue. I think.
Sorry for the interruption. Am I audible?
Yes, you are.
I
Yes.
Yeah, okay. So, before making, before starting something therapeutic to this to correct this anemia, it's very important to have this workup, which is essential to exclude correctable causes before initiating potent stimulating agents like darbepoetin. That's why it's very important to get.
Sir? Sorry, sir, we are unable to hear your voice. I think you are facing some network issue.
Yes, next slide. Sorry. Yes, am I audible?
Yes, sir.
Okay, so let's coming to, sorry for the interruptions. I don't know, maybe some network area from the IT side. So let's come to some data. So as per this study, we have this incidence of chemotherapy-induced anemia. So from cancer-induced anemia, now coming to chemotherapy-induced anemia, where the anemia is actually only because of chemotherapy-induced chemotherapy and not because of other factors like blood loss or iron deficiency or chronic kidney disease or maybe bone marrow suppression due to cancer itself. So, if it is chemotherapy-induced anemia, it generally leads to significant anemia, as low as hemoglobin less than 8 gram per deciliter in 1 out of 5 non-anemic cases, typically striking after 3 or 4 cycles of chemotherapy. Next slide. So, as we can see, as per uh, this literature, incidence has been found to be very high in gynecological, lung cancer, multiple myeloma, leukemia, breast, colorectal cancers, and gastric cancers. From 81.4% in gynecological malignancies to 50.7% in urogenital malignancies. Next slide. So, this is the data which shows that we want a level of hemoglobin to have a better outcome. So as we can see through various studies, suppose to have a better outcome. In colorectal cancer, it has to be around 10. In breast, it has to be around 10.5 pre-chemo. So generally, we take it as around 11, and if it is less than 10, we do some intervention.
Sorry, sir, your voice is breaking. We are unable to hear your voice properly.
Yes, next slide. So, as we can see, overall tumor causes inflammation. It activates the macrophages, which release IL-6 and reactive oxygen species, which stimulates liver to produce hepcidin. And because of hepcidin, there is this functional efficiency. Iron from the iron because so our body feels that iron is available in sufficient quantity, and that's why endogenous erythropoietin production gets suppressed. So it's like a functional deficiency of iron, but at the same time erythropoietin production gets hampered, uh, unlike the regular iron deficiency situations in our body. Next slide. Along with the functional iron deficiency, such patients, they also get blood loss and pre-existing malnutrition, which leads to absolute iron deficiency. So we have gastric cancers, gastric malignancies, suppose colorectal cancers or stomach cancers, which cause upper GI or lower GI bleed, which cause which cause decreased blood levels and hence anemia within the body. Then overall, because of inflammation, there is a functional iron deficiency. Overall, because of pre-existing malnutrition, there is actual iron deficiency. So there are multiple etiologies to have anemia within a cancer patients. Next slide. So why patients' blood management matters in the immune checkpoint inhibitor era? We are using now immunotherapy right, left, and center. And as we can see here, restrictive triggers, for example, around 7 gram per deciliter is safe. So practical goal is reserve unavoidable transfusions, correct anemia or iron deficits before patients need blood. Because transfusions, they bring multiple antigens within the body, and the immunotherapy agents, they get used in handling those antigens, and because of that, the outcome, those immunotherapy agents, they are not able to manage cancer antigens. Next slide. So working definition, if hemoglobin is less than 7 or symptomatic anemia or active bleeding or acute coronary symptom despite optimization, then we need to transfuse. So as less as 7 has to be the cutoff for transfusion. Between 7 to 11, various types of erythropoietin stimulating agents should be used. So we should always symptoms, signs, and comorbidities, and not even if even then hemoglobin is falling trend. And they are aggravating the comorbidity. Next slide. So this we have discussed. We can have absolute versus functional iron deficiency, and this is very easily evident by transferrin saturation. When transferrin saturation is more than 50%, the patient is actually not having any iron deficiency, but even then patient is showing iron parameters related to iron deficiency anemia, then it can be because of functional iron deficiency. So in such situations, iron supplementation are not indicated and ESA monotherapy should be used. So the whole thing is that if iron parameters are showing iron deficiency, but at the same time transferrin saturation is more than 50%, iron supplement should not be used. If transferrin saturation is between 20 to 50%, functional iron deficiency anemia should be considered as an etiology, and oral iron alone will not be effective. In that case, IV iron plus minus ESA is preferred. So this is very important that between 20 to 50%, we have to give both erythropoietin stimulating agent as well as IV iron. And if transferrin saturation is less than 20%, then it is an absolute iron deficiency and iron replacement therapy is mandatory. IV iron is preferred. So this whole thing that ferritin and transferrin saturation, they have to be correlated, and ferritin will tell about the iron store and transferrin saturation will tell about the functional status of iron. So we have to correlate both the parameters before making the diagnosis of iron deficiency, and the therapy also changes subsequently. Next slide. So if hemoglobin is less than 10 or suppose 11, we have to confirm that it is actual iron deficiency or functional iron deficiency. For this, we have to get ferritin, transferrin saturation, and C-reactive protein. Suppose patient is having actual iron deficiency, we have to give IV iron, and if it is functional iron deficiency, then we have to give IV iron plus erythropoietin stimulating agent. As we discussed, initiate ESA if chemotherapy-induced anemia and non-curative hemoglobin less than 10. Transfusion should be reversed should be reserved for unavoidable scenarios. Next slide. So, erythropoietin stimulating agents may be offered for chemotherapy-induced anemia when hemoglobin is less than 10 in non-curative settings. There should be some lowest hemoglobin cutoff institutionally to avoid transfusion. Generally, it is taken at around 7 gram per deciliter. IV 50%, then only erythropoietin or IV iron should be given. Next slide. What is a role of this whole practice in current era in oncology? So as we can see that there is advent of immunotherapy in all the treatment guidelines. Immunotherapy has changed the outcome of so many of almost all the malignancies. And that's why, because blood transfusions, they generally are negative. They interact negatively with the immunotherapy. It is very important that blood transfusion should be reserved, and they should not be used liberally in patients receiving immunotherapy. Allogenic RBC transfusion can trigger transfusion-related immunomodulation, which is a plausible mechanism for reduced immunotherapy efficacy. Next slide. So as we can see, allogenic RBC transfusion, they have residual leukocytes, they have microparticles, they have cytokines, soluble HLA factors, and free hemoglobin. They generally reprogram the immune cells, antigen presenting cells, and they also cause expansion of the regulatory T cells. They cause energy to suppressor T cells. And because of that, the killing of T cells, they get hampered. And that's why the role of the mechanism by which immunotherapy acts, that it brings the T cells to the killer T cells to the antigens on cancer cell by the immunotherapeutic agents. Then there is more immunosuppressive signaling. So immunotherapy agent as a whole gets suppressed. And then there is potential loss of immunotherapeutic agents responsiveness, and then possible shift in infection or inflammation balance is seen. That's why, because of this whole immunomodulation, the outcome related to immunotherapy gets hampered. And that's why blood transfusion should be done very prudently. It should not be we should not do it liberally just to target some hemoglobin. We should be very careful with that. Next slide. So as we can see how transfusion tumor micro environment gets affected by blood transfusion, along with dampened response to immunotherapy, overall tumor microenvironment gets disintegrated. There is increased VEGF activation, which causes more angiogenesis and hence a better spread for cancer cells. and there is altered oxygen delivery also. So sometimes, the tumor hypoxia gets reversed because of blood transfusion, and immunosuppression is also seen. So overall, the dysregulated blood transfusion causes increased in causes favorable effect on tumor growth and unfavorable effect on role of immunotherapy on the tumor cells. Next slide. So ACT response is to engage with advanced or metastatic solid malignant tumors treated with immunocheckpoint inhibitor, managed at single tertiary cancer center. RBC transfusion was administered within the 60 days after initiation of immunotherapy. The comparator arm had patients who have not received RBC transfusions at all, or who received RBC transfusion within 13 days before initiating immunotherapy. So, and they have compared the outcome as overall response rate and immunotherapy related adverse events within 60 days of initiation of immunotherapy. Next slide. So as we can see the result, there was definitely a significant response to the dampened outcome. And next slide, please. This is generally this is on overall. Yeah, so there is dampened response. There is 30% reduction in the treatment response rates. Non-transfused patients had a better response rate of about 77.5. Transfused patients had more than equal to 2 times higher immune related adverse events also as compared to non-transfused patients. So both the things were a problem. There was a reduction in the treatment response rate, as well as there was increased immunotherapy related adverse events also. Next slide. So this was the same thing. There is this different another study by Oilia et al. The effect of PRBC transfusion on the clinical efficacy of immunotherapy, and they have also shown the same thing, that the response rate dampened and there were increased incidence of immunotherapy related adverse events. Next slide. As we can see, there was shorter PFS of 3.9 months versus 8.2 months in transfused versus non-transfused category. And overall survival was also lesser. There was 13.8 months versus 6.1 months in transfused versus no transfusion category. So it's quite a significant difference. Like it's a difference of about, for PFS, it's a difference of about 4 months, and for OS, it is a difference of about it's quite a good number. It's more than 10 months. Next slide. So definitely there was negative association between transfusion and progression-free survival and overall survival uh, in this study. Next slide. Next slide, please. So coming to what's the solution? So we have this erythropoietin stimulating agent. It's a darbepoetin alpha, and it has been studied in detail in advanced NSCLC. It was a randomized double-blind placebo-controlled phase 3 non-inferiority study of the long-term safety and efficacy of darbepoetin alpha for chemotherapy-induced anemia in patients with advanced adenocarcinoma lung. And as we have discussed, what was the clinical reality that chemotherapy and induced anemia is deeply prevalent in NSCLC and drives severe fatigue and requires frequent risky RBC transfusions, and erythropoietin stimulating agents remain the primary mechanisms to enhance RBC production. And prior trials have also shown that breast cancer patients had good outcomes with erythropoietin stimulating agents, and uh, ESAs have triggered immediate REMs and apprise mandates by the FDA and EMA to ensure benefits outweigh survival risk. So, as per mandate, it proved a strict non-inferiority in survival before claiming any efficacy in anemia management. Next slide. So this was a trial design. It included patients with stage 4 NSCLC expected to receive more than more than equal to 2 additional cycles of first 6 months, and the treatment protocol was also randomly double-blind randomization with 2:1 patients, and darbepoetin alpha was given 500 microgram versus placebo every 3 weekly. And we had they have measured overall survival, progression-free survival, and comparison with RBC transfusion. Next slide. So baseline demographic, I think we can skip this slide. Next slide. So if we see this, OS curve and progression-free analysis, as we can see, there was this darbepoetin arm had a median OS of about 9.46 months versus placebo, which had 9.26 months. So there was not a much difference, which showed that darbepoetin doesn't cause much effect on the survival. And median PFS also was very similar. So we can safely use darbepoetin alpha without any effect on or impact on overall survival or progression-free survival, as we can see through this study. Next slide. Coming to serious adverse events, generally they were identical, and 2.8% patients had shown DVT, which was almost similar to the placebo arm also. So even thrombovascular events remain low and consistent with the expected baseline for an advanced NSCLC population receiving myelosuppressive chemotherapy. Next slide. So why this trial design succeeded? It was used in adenocarcinoma lung, whereas this EPO ANE 3010, it was used in breast cancer. In breast cancer study, they have used erythropoietin alpha, whereas in this is non-small cell carcinoma lung, they have used darbepoetin alpha. And even if we see the gender split, the current study had 66% male, whereas in the EPO study, it was 100% female. And median age was also higher. And the endpoint was PFS in EPO NA study, whereas the endpoint was OS in current study. And Perhaps these were the reasons for the failure in EPO and A&E study, because it was already it was because they were majorly used in female patients who are anyway anemic, and erythropoietin alpha uh, might have created confusion. So the failure of EPO-NE 3010 in younger female breast cancer patients highlighted the need for distinct cancer-specific safety data. The current study definitely answered that mandate for the NSCLC patients. Next slide. So as we can see that blood transfusion is definitely overall a hazardous procedure, and it should be again used prudently and not liberally. And erythropoietin stimulating agents, they stimulate bone marrow physiologically. Um, they give the sustained maintenance of hemoglobin, and overall they don't impact the overall survival as compared to blood transfusion. Next slide. So we have discussed this again and again. The RBC transfusion is associated with both short-term and long-term clinical considerations. Even RBC transfusion is associated with venous thromboembolism, and hence ESA, we can avoid all the negative impact on overall survival and short-term side effects also, like thromboembolism, which as we have seen in. Next slide, please. So we have also synchronized dosing of chemotherapy with darbepoetin alpha. If we are using 3 weekly cycle, 500 microgram dosing is quite an adequate dose, and mostly we use 3 weekly cycles. So 500 microgram dose is overlapping with the chemotherapy administration, and it's logistically also uh, easier to administer. So also it's just a subcutaneous administration, so we don't need much IV patient get can. Next slide, please. So definitely synchronizing the dose of darbepoetin alpha with 500 microgram 3 weekly, they are going to help us logistically, because then patient will have a fewer visits. We are going to give it weekly. Definitely patient will have to come again and again. So there will be fewer visits. There will be less time toxicity, and then it will be easier to administer. The patient will also be welcoming this treatment regimen. There will be lesser pricks and more independence, and hence this 21 days dosing with 500 microgram or bi-weekly dosing with 200 microgram is quite a good um, regimen. Next slide. So what is the final guideline concordant element? Patient receiving myelosuppressive chemotherapy for cancer treatment that is not curative in intent, with hemoglobin typically less than 10, after evaluation of reversible causes of anemia, can be given this erythropoietin stimulating agent, which raises hemoglobin, reduces the need for RBC transfusion. Multiple trials and pooled analysis showed transfusion is sparing benefits when initiated appropriately. It should be used at the lowest dose sufficient to reduce transfusion, replete iron when indicated, and monitor for ESA related risks such as thromboembolism. So it reduces blood transfusion exposure, therefore can help the help the IO efficacy also. So with this, I think it's the last slide. Thank. Next slide, please. I think it is the last slide. Thank you. Thank you for having me. Thank you for letting me participate in this nice seminar, CME. Thank you.
Thank you, sir. As we reach the conclusion of this program, we would like to thank all our faculty and their time for expertise and our audience for their active participation. A special note of gratitude once again to our program director, Dr. Tushar Pandey, for his leadership as a program director. All the participants will be receiving their certificates within 4 to 5 working days to your registered mail ID. I repeat, all the participants will be receiving their certificate within 4 to 5 working days to your registered mail ID. Thank you for joining us this evening. Have a wonderful day ahead. Thank you.